Recording. Oh, look at that. Perfect timing. All right. Well, welcome everyone to, and hopefully you can see that all right. Looks like it's fine. Welcome to our April 26th session of Project Echo Dementia. You are familiar with our process, but just as a reminder, we will just do some brief opening notes and some reminders. If this is your first time, we'd love to meet you. So if you want to throw your information into the chat, that would be wonderful. And then we have the great good fortune of our own Dr. Barak Gaster talking about advanced care planning. We do not have a case, although Dr. Gaster has assured me that he has many vignettes and case examples. And I think this is a topic that engenders itself to a lively discussion. So we will have plenty of time, and certainly feel free to bring up, clinically pertinent issues or burning questions. And if we have free time, we can always bring up other topics too. So we'll plan for that. A couple of reminders, if there are multiple of you in the room, please list everyone's names in the chat just so we can keep track of attendance. If you're able to, great to turn on the video. If you can't, we understand that too. And I think everyone's named appropriately, so we don't need to worry about that. CME for any of our UW faculty, staff, or students. This is the number to text your information to. And we'll remind you of this at the end also, just to make sure that's complete. If you're not a UW affiliated provider, we will keep track through our usual mechanism, and Sammy will reach out if she needs any more information from you. Just a reminder of a few other accredited series that may be of interest around brain injury or psychiatry and addictions or behavioral health. Also for any issues around pain and opioid clinical issues, a couple of those, and the repository of grand rounds from UW Psychiatry. We should throw the neurology and neurosurgery ones on here too. Those are also treasure troves of excellent clinically oriented information, including a lot of dementia specific info. Reminders, we don't have a case today, but in any clinical discussions, do your best to protect PHI. We can always edit it out later, but better to prevent than treat. We are accredited for CME. Each session is eligible for 1.25 credits. We don't have any disclosures. Anytime there are any financial relationships, there's a stringent mitigation process here at the University of Washington. Here is our hub team. And here are all of you out around our great state of Washington and some other border areas that serve people from Washington. I think, we implicitly hinted this, but we are always open for new members. And I am so impressed with how many people come to us via word of mouth. So if you have colleagues who may be interested or would benefit from their involvement in this great community, please feel free to share our contact information, and either Sammy or myself or Nancy are always happy to talk with folks about Echo. And that brings us to today's didactic by our own Barak Gaster, talking about advanced care planning. So I'm going to stop sharing now, and I'm going to turn it over to you, Barak. And just as I guess another word of introduction, many of you know that Barak has authored the advanced care planning document for dementia, but is also spearheading really excellent work around cognition and primary care, which would be great to have you come back and talk about that as well at some point. Or if you want to weave that in today, feel free.
No, I think we've got that on the schedule for September, I think maybe, but which is a good time because we are right now at the end of collecting the final set of data for the rollout to the 14 UW primary care clinics for the cognition primary care program. And so we're sort of at the end of that and sort of analyzing all that data. And so it'll be exciting to share those final results with you all. I think it's in September 13th. Thank you, Samantha. And but today what I want to talk about is, in a way, the core concept that really kind of drew me into dementia care at the very beginning, which is advanced care planning. And really one of the hardest parts of advanced care planning is advanced care planning for dementia, and just is so kind of essential as a way to get us to what many people are increasingly acknowledging and realizing is better care. So care that is aligned with people's wishes. And so without further ado, let me get into it to think about just a little bit of like why is dementia such a hard subset of advanced care planning, and so much of it is that this is a psychologically hard disease to consider. It's hard for patients who may be beginning to experience cognitive impairment. It's hard for family members to see their loved one changing, and it's hard for people in healthcare to open up what can feel like a really difficult sort of uh, you know kettle of fish, can of worms of like, boy, what are we do I really want to delve into this like really sort of tricky and emotionally difficult topic. And so it just is so tempting for just about everyone to not face the possibility. I mean, it's hard to face the possibility of our own decline in general, or our own, future sort of like end of life decisions. But when it is really related to also losing cognitive function, then it's really even more tempting to kind of maybe pretend that it's not happening, and or even pretend that it might not even maybe happen in the future. And so really a lot of the first initial approach is to think about how to sort of to sort of turn the curtain away and really say, no, this is actually something that is a good, important thing for us to talk about, because we really can make care better for our patients by talking about it and by planning for it. And to think a little bit about like, why is dementia unique? I like, as I was first starting on this topic, boy, it was like 7 years ago now. I remember one of the leading palliative care experts in the nation was here speaking in Seattle, and I was at a palliative care conference, and I went to him, wanting to just bounce the idea off of him of like, what about a dementia directive? And I remember him, being a little bit flippant and being like, gee, do we need like a directive for COPD and a directive for, diabetes and a directive for kidney failure? To him, it took me a little while to get him to sort of understand, like, no, dementia is kind of unique. And one of the main reasons that dementia is unique in terms of advanced care planning is that relatively early in the course of this progressive disease, people lose the ability to guide their own care. And so, unlike many other chronic conditions like heart failure or emphysema, COPD, people really still have full decision-making capacity until like very, very, very late in the course of their illness. Whereas that's not the case for dementia. Dementia is different in that way because of that loss of the sort of capacity to make decisions for their own, and how so often family members, caregivers are put into what can be really difficult positions of needing to make decisions on behalf of their loved one for many, many years. So it's not just in the last sort of week or 2 or 3 of their illness, but it's like for maybe the last 3 or 4 or 6 years of their illness. And that course can often be really rough, as you all know, that this is often a very difficult disease for people to go through, where they can very commonly go through periods of agitation and combativeness in which people's quality of life can be really not good. And that many people would want a gradual shift to comfort-focused care as they progress along a dementia illness. But to figure out when might that shift happen and how to decide is really, really tricky. And I think that is really sort of the case for why dementia is unique among all of the diseases that we face near the end of life. And that advanced care planning is really all about helping to align the medical care that people receive with the medical care that they would have wanted. And like I mentioned before, increasingly this is identified and defined even as higher quality care, that when that a really important metric for us for thinking about, what is high quality care in the last year or two or three of life. Really, it should be care that is aligned with what people would have wanted. And so the first thought that I remember having this like light bulb moment when I was and this was like even further back, 10 years, 12 years ago, which was like, still like 10 or more years into my career, was the first time that I actually sat down and read what's in the standard state of Washington advanced directive, which is actually very similar to what is most states' standard advanced directive across the nation, which is a very, very sort of densely written at very high literacy level legal document. It really reads almost like it's like written by lawyers for lawyers almost, that really focuses a lot on very, very rare conditions, like if I'm in a permanent coma or if I'm in a persistent vegetative state. And it's not that those aren't really important conditions to document your wishes about, because those can be really difficult situations. And I think it really does speak to this as a very legal document, because they came from very difficult, legally challenged cases, situations. And yet the odds that any of our patients are ever going to be in a permanent coma or a persistent vegetative state is like 1 in 10,000. And so it's not that it's not important to state your wishes if you're in one of those states, but it's really important to acknowledge that the odds that you're ever going to be in one of those conditions is really tiny, whereas the odds that somebody over age 65 might be someday facing dementia is more like 1 in 3. And so, it's for that reason, it's a little bit shocking and sad that there's like almost nothing that really applies to dementia in a standard advanced directive, which is what most people fill out and feel like, oh, I've got that taken care of because I've filled out that living will. And yet there's really hardly anything in there that you can really sort of hang on to help guide care for somebody with dementia. And part of the reason for that is, as you all know, dementia is a really complex illness that people with early dementia can still have many years with very, very good quality of life, but that there is often a slow decrease in quality of life as people move from the mild to the moderate to the severe stages of the disease. And so it makes sense that people would generally want different goals for their medical care from one stage to another. And this is like a beautiful photo that comes from the Greenwood Senior Center, where it really just makes that point of like, it's not like some sort of like switch gets flipped when you get diagnosed with dementia, and then sort of all of a sudden your quality of life is gone, and sort of like, oh, it's like it's the end of the road, it's comfort care only. That it's not like that. This is a complex disease that people have varying opinions and wishes preferences about. And that's why it's just so important to really try to make sure that we are doing our best to elicit patients' preferences when we can. Because a lot of people have very clear ideas. And so this was a study that was done now 15 years ago in Boston, where they took 200 people over age 65 who did not have cognitive impairment, and they showed them pretty well-balanced depictions of what it's like living with dementia. And if anything, I think they erred on the side of like, of not making this like horrific looking, but if anything, sort of like making it look a little bit better than it actually might be in most situations. And these people watched those videos and then were asked what they would want for their own care if they were in a living in a state like that. And actually 72% of those 200 people indicated that they would want comfort-focused care only. And that, I think, is that sort of resonates pretty well with me in terms of my sort of years of having had conversations with people about this. And yet that's really just not what happens most of the time. I think most of the time the juggernaut of the healthcare system tends to provide more care than this than probably people would have wanted, because it is so hard to sort of guess and know what people would have wanted. And so, that really is what led me sort of 6 years ago now to think about, well, how can we help people communicate their wishes? How can we elicit people's preferences and wishes while they're still able to communicate them? And that's what led to the dementia-specific advanced directive that Chris mentioned, which is developed with input from experts in palliative care and neurology and geriatrics, tested and refined in primary care, and made available for anyone to download for free from the website dementiadirective.org. And so here's a screenshot of what that website looks like, where you can click on that green button and download the Dementia Directive. It's got instructions on how to do it. It's got frequently asked questions about it, resources, and it was sort of featured in the New York Times like many years ago now, and that is really what sort of like exploded the traffic to this website that really has, though, continued in the 6 or 7 years since then, where this website still gets about 2,000 visitors per month from people around the country who I think most of them are just kind of like Google searching for, living will for dementia, and that's how they end up finding it. And so just to give you a brief overview of what the Dementia Directive looks like, it is really designed to be like very, very sort of easy. I think from my primary care perspective, I was just aware that the more complicated and elaborate it was, the less likely people were to fill it out, and the less likely we were to get some sort of inkling of what their preferences would be. And so it really is very concisely designed as brief descriptions about what mild dementia is often like, and what moderate dementia is often like, and what severe dementia is often like. And those brief descriptions were sort of difficult and sort of elaborately wordsmithed with input from lots and lots of people to make sure that they were presented in as sort of complete and balanced a way as possible, with the real acknowledgement that nobody, that if you take everybody with moderate dementia, no two people are, experiencing or living through exactly the same thing. And so it's really designed to be, here's a common situation that somebody with moderate dementia might be in. And so if you were in a state that was kind of like this, do you have an idea of what you would want the goals for your care to be sort of at that stage? And here also what the options are under that description have also been sort of, you know, carefully sort of thought through and revised over the years, and ending up sort of closely matching what are the options on the POLST form. And I think part of the rationale for wanting to sort of have some alignment there was that when you do have a dementia directive that somebody filled out from years ago, you really want it to be as useful as possible for setting the goals of care now, which is, and the POLST form is often one of the most important documents for helping to do that. And we're going to talk about POLST a little bit later, but I just want to call out here how the options that are available on the dementia directive form are by design relatively closely aligned with the options that are on the POLST form. And so here is an even briefer version of the brief descriptions on the dementia directive form of what mild dementia is often like, and what moderate dementia is often like, and what severe dementia is often like. And, you know, I think one of the most sort of important improvements that happened along the sort of many years that the dementia directive has been available was actually input that came from Randy Curtis, who was like absolutely an amazing sort of like giant in the field of palliative care here at the University of Washington, who really helped the development of this directive from its very beginnings, and gave lots of input as it was developed. And you know, absolutely heartbreaking that he passed away 4 years ago or so from relatively early ALS. And so I just want to kind of acknowledge the intense sort of debt I have to Randy Curtis, and really helping to make sure that the dementia directive includes like the why somebody might choose these different options, and that it's not just like, you know, click on this box, click on this box, but it does really try to give people some context of why they might say, gee, I don't think I would want CPR or intubation if I sort of was at that stage. And this is this is, you know, language that's in the dementia directive now that is really one of the most important things that I frame for people if I'm sort of leading them through the dementia directive in person, which is no question like a better way to introduce the document to somebody, that a lot of the people who are finding this document online and are downloading it and hopefully sharing it with their care team and their family, it's a little bit sort of tricky, and that's why the frequently asked questions that are on the website and actually are in the document itself hopefully can lead people through. But I think what's helpful for you all to hear maybe is how I am really careful to really focus in on this specific issue of why somebody with even early stage cognitive impairment might say that they would not want CPR or intubation in the case of something catastrophic happening. So CPR happens if you have a sudden cardiac arrest, or intubation happens if you have severe sort of respiratory arrest, such that you're, say, having pneumonia that's so severe that you're unable to breathe on your own, and so you might need to be hooked up to a ventilator in the ICU. And so the way that I frame this for people is, if somebody who has cognitive impairment has a catastrophic event like that, where their heart stops or they're unable to breathe on their own and they need to be hooked up to a ventilator, even in the event that they were to survive a resuscitation or a stay in the ICU, they would be at very high risk of having worsened cognitive impairment after sort of having survived an event like that, and that might not be a worsened state that they would necessarily sort of want to survive in. And so that's the reason why somebody might say, gee, I would want medical care to prolong my life if I was at that stage of dementia. But if I had something really catastrophic happen, like a cardiac arrest or a severe pneumonia where I was unable to breathe on my own, then I might say, gee, I would not want CPR or I would not want intubation. And that is like a useful sort of preference to know about ahead of time before that happens, or before they are in that state of dementia, because you can then help use that preference to fill out a post form to really better align the care that somebody gets with the care that they would have wanted. And in the similar way, the why for comfort-focused care is because of the increased risk of adverse effects of agitation and more complications from life-prolonging interventions that somebody can experience. That higher risk of adverse effects is a really real and important thing to acknowledge for somebody who has dementia, and that somebody very well might prefer sort of fewer or no life-prolonging interventions, but only interventions that are focused on treating people's symptoms and keeping people comfortable. And so since this website has gone live 7 years ago, my email address is actually on the website. And so I still get emails from people around the country, sometimes asking me questions about it, but a lot of times just sort of thanking me. And so, really, I think this document resonates for a lot of people of like, I've been looking for a way to sort of express this in a structured way with my family. And so thank you so much for giving me a vehicle, an instrument to do that with. And so I'll tell you the funny story of the development of this dementia directive was actually as I was beginning to develop it and beginning to use it with my patients. My initial thought was that the most important situation to offer somebody a dementia directive would be at that very, very early stage of mild cognitive impairment. That's a stage where you're much, much more concerned that somebody may be facing dementia down the road. And so, boy, oh boy, that's the situation where it's going to be the most important to offer somebody a dementia directive. And very interesting experiences that I've had over the years that I've, happy to share anecdotes about of how much when I offer the dementia directive to somebody with mild cognitive impairment, I will almost always get like, oh my goodness, thank you so much. This is great. I will definitely take this home and I'll think about it. And, I'm really sort of, I will gladly fill it out. And then I see them back 6 months later and I ask them about it and like, oh yeah, right. I think that's like, I think I've got it on my counter still. Yes, I will do that. And I ask them again, maybe 6 months later or a year later. And it really turned out to be something that many, many people with mild cognitive impairment have a difficult time filling out. And at first I thought that was just because of the psychological sort of shock of what is often a new diagnosis of mild cognitive impairment, and that it's just kind of scary for them to sort of think about this, and they're still not used to the diagnosis, and they can't really sort of face filling out a directive like this. But then really when I would see somebody back 1 or 2 years later and they were much more kind of accepting and at peace with the diagnosis, it was still really almost impossible for many of them to fill it out. And I started to realize that it was maybe not a psychological barrier as much as it is potentially a physiologic barrier, that one of the very first executive function sort of tasks that our brains lose in the course of, say, Alzheimer's disease is an ability to imagine the future. That it's easy for somebody to sort of make a choice right then and there of like, here, this is what I want right now. But the imagining a future state of oneself is actually a pretty complex sort of cognitive task that we take it for granted so much and I think this applies to really kind of many types of planning for somebody with mild cognitive impairment, that like making plans for like a month from now of like imagining an event a month from now, and how are we going to organize sort of that event is a complex and difficult task for somebody with mild cognitive impairment. And I think that doing advanced care planning is almost in that same ballpark of imagine a future state of yourself. What would this future state of yourself want is almost impossible for many people with mild cognitive impairment. And so instead of offering the dementia directive to people, to my patients with mild cognitive impairment, I started offering to everyone over age 65. And instead of getting almost none of them back, I started getting almost all of them back because, as I mentioned before, this really is a topic that a lot of people do have really clear sort of ideas and are really sort of like happy to have an opportunity to express their wishes about it. You know, the next biggest question I get about the dementia directive is, you know, is it legal? You know, like what is the legal status of this document? And you know, there I really sort of make the important point that just advanced directives in general are sort of not like legally binding sort of algorithms. That generally speaking, like when we speak about a living will, a living will is really there as a general guide for families. You know, it's a general guide to help your durable power of attorney for healthcare, your surrogate decision maker, your family, your loved ones, make decisions on your behalf, and that the advanced directive is there, you know, not as anything that is like set in stone and this is exactly sort of what you're going to follow, because we can never imagine the many different situations that somebody might sort of find themselves in the future. And so it's really there as a general guide to inform us of patients' values and preferences. And so it shouldn't be legally binding. You know, I think when you fill out a durable power of attorney form, which we'll talk about in a second, that's a very legally binding document. But a more general advanced directive, which we think of as a living will, really should never be legally binding. Instead, it's there to provide guidance for proxies and clinicians who might need to make decisions on your behalf in the future. And so that's really one of the main reasons that that we decided not to put a place on the document for a notary or witnesses, because the moment that you even put that on a form, it becomes this barrier to people completing it, because they look at that and like, oh boy, I'm going to have to figure out like how to get this witnessed or how to get this notarized, and I'll get to that later. And it's just not going to happen. And fewer will get done. And that in many ways, like the risk of conflict or uncertainty, if people don't have a directive at all, is greater than the risk of conflict or uncertainty if they have a directive that they've signed, but it didn't get witnessed or notarized. And, you know, there was a brilliant essay in the New England Journal now 7 years ago that, you know, really, you know, like, you know, let's delegalize advanced directives, which is, you know, the idea that putting a requirement for witnesses or notary on them just like puts them into this kind of almost like false legal status that really sort of is a barrier to getting people to fill them out. And so again, this is different from a durable power of attorney for healthcare, which in some ways can be thought of as an advanced directive, but here really speaking about general advanced directives or living wills like the dementia directive that really shouldn't be legal documents, that this is a structured way to communicate your wishes and have a conversation with your potential future decision makers. And so I really think of it as this can be a supplement to a standard advanced directive, but can also stand alone. And if people are concerned that their wishes may be sort of overruled or ignored or discounted, then anybody can take any document to a notary and sign it in front of a notary who will sort of then sort of stamp it and say, yes, I saw their driver's license when they signed this, and in the powers vested in me by the state of Washington, I attest to the fact that they signed it in front of me. Absolutely, somebody can still get it notarized if they are worried about a legal challenge, but that is sort of not needed, and that's the reason why we don't have that on this document. And just like thinking about what the value of a dementia directive is really a guide to help people express their preferences. And I think really thinking of it as a communication tool, that it's not a rigid legal algorithm, but it really is a structured way that you can communicate, have a conversation with your loved ones that they can sort of think back on, and then actually have like documentation to say, oh yeah, I remember that conversation that we had, and oh yeah, and I'm going to pull out that document that they gave me, and this is really a really kind of like anchoring sort of document that helps me to remember what somebody's preferences and wishes were. So now I want to turn a little bit to sort of like, what about when somebody has mild cognitive impairment or even early dementia? And, it's not that they can't sort of be offered a dementia directive to fill out, but like I said, it is often they are starting to lose the capacity to really imagine sort of a future state of themselves and express what they would want for that future state of themselves. And there, though, what they are still able to do, generally speaking, have full capacity to do, is to identify who their durable power of attorney for healthcare would be. So who are their proxy decision makers? And here, I mean, this is the most important aspect of advanced care planning that is part of the cognition and primary care program. That is, one of the most sort of important benefits of making an earlier diagnosis of cognitive impairment, is to help somebody to fill out a durable power of attorney for healthcare early in the disease. So important for them to do it as a legal form that you want them to get witnessed and or notarized, because you want them to identify not just who is the first up person that they would point to as their surrogate decision maker, but who's the alternate to that person if that person wasn't available. Because most people sort of walking around, even if they're in their 70s or 80s, don't have durable power of attorney for healthcare forms filled out. And that's okay. It's not a big deal because generally speaking, every state, including the state of Washington, has very well defined sort of like, people who are the default durable power of attorney surrogate decision maker if somebody's not able to make decisions on their behalf. And that is the first sort of person on that list is your spouse. And that is generally who somebody would say, this is the person who I would trust the most to make my medical decisions on my behalf. What's different about and unique about a dementia illness is that somebody with mild cognitive impairment is likely facing like a 10 to 15 year sort of journey of their dementia illness. And it is very possible that their default person, usually their spouse, may not be available to serve in that capacity sort of 6 or 7 or 8 years from now. And by then, it might be too late for that person to have capacity to say who the backup to that person is. And so the real sort of value of filling out a durable power of attorney for healthcare for somebody with mild cognitive impairment is not to identify who their sort of first up decision maker would be, because usually it is the default spouse person, but who's the backup to that person? Who's the, is it, one of your 6 kids? Is it your next door neighbor? Is it your good friend? Is it your niece or your nephew? Somebody who might not be sort of automatically identified sort of on the legal sort of hierarchy. But that is the person who you can, likely have still full capacity to identify as your alternate. So important to help somebody with mild cognitive impairment fill out a durable power of attorney for healthcare form. Because it really it's all about conversations. I think, the people who kind of chafe against advanced directives really sort of like point to, like, yes, an advanced directive, a living will is important, but really what's important is conversations. And that's absolutely the key. And I think that thinking about a most advanced directive forms are really vehicles to sort of help sort of structure and facilitate conversation that is really, I like to use the term a lot when I'm talking to family members of people who have moderate to severe stages of dementia, to really sort of talk in a gentle, sort of open-ended way, like, if your loved one could look on themselves now, if your loved one from 10 years ago or 15 years ago could look on themselves now, what do you think they might have said that they would have wanted? And it's really important to include considerations of what the potential harms of tests and treatments would be, to help to fill out a pulse form, as we're going to talk about in a second, and or just to help sort of guide a decision that might be sort of right in front of you, of like, should we do this surgery or not, is really important to try to sort of conjure up that person from before, sort of, because I think we really do want to honor people's wishes. I think we are still so grounded in trying to sort of skate towards autonomy, so that people, even if they're not able to make decisions about their own care now, really trying to imagine, the person who, used to embody that who used to be in that body, what would they say if they could fully understand the decision in front of us? What would they say that they would want? And that's the having a conversation. The Conversation Project is a nonprofit in Boston that has a very beautiful dementia specific guide to help families navigate through a conversation like that. So I mentioned the pulse form. The pulse form is absolutely essential as a goals of care, advanced care planning document. A really important change that happened in the state of Washington maybe 5 years ago now was they kept the same acronym, POLST, so it could still be called PULST, but they changed what that first word stood for. It used to stand for physician order for life-sustaining treatment, but because in the state of Washington, thank goodness, it doesn't have to be a physician who's signing that document. It can be a nurse practitioner or a physician assistant. They changed it to portable order for life-sustaining treatment. I think that word portable is so important, because I think the main value of a pulse form is its portability, that it is, in some ways, it's there, to put on your refrigerator in case 911 is called, and the medics arrive. They can sort of immediately see whether somebody would have wanted CPR or not. And that was the initial sort of intent of the pulsed form document in general. But I think really the way that I teach about it as like a much more kind of like useful document than that, more likely to sort of be applicable, is that it is portable from somebody's sort of living situation to another. And so if somebody sort of moves from their home to an adult family home, or moves from their sort of home into a skilled nursing facility, or if somebody is brought into an emergency room, that document can sort of travel with them and be like a legal document that shows what the goals of care conversation that happened before, so that if somebody shows up in the emergency room, as you all know, their code status still needs to be sort of addressed, and it's still, the pulse form is not going to necessarily be the legally guiding document. But rather than that sort of code status conversation sort of happening as this blank slate, if a patient comes to an emergency room with a pulse form, like all of a sudden that goals of care conversation, let's set your code status now that you're here in the hospital, is starting from the conversation that happened before, which identified what somebody's preferences for care would be. And then especially if somebody then leaves the hospital, say, and goes to a skilled nursing facility, skilled nursing facilities are required for somebody to have a pulse form. And if they come from the hospital to the skilled nursing facility, it's a portable sort of communication across sites that sets somebody's goals of care now. So unlike the dementia directive, where it says, if you're in this future state, what would you want the goals of your care to be? The pulse form is, what are the goals of care now? If you have cardiac arrest now, if you have severe pneumonia where you're unable to breathe on your own now, is the preference for comfort focused care, for ICU care, or for full treatment care? And that's really the value of a pulse form as an incredibly important document to help patients and families fill out as a dementia illness progresses, in a way like using the same sort of why conversation anchors that I talked about for the dementia directive, of why somebody with moderate dementia might not want CPR, in addition to the fact that their survival is probably somewhat lower. But even if they were to survive, if they go through a period of no blood flow to their brain, it is likely that even if they survive that resuscitation, their cognitive impairment is going to be significantly and permanently worse than it was before that cardiac arrest happened. So like I said, so these are like the important whys to remember when you're helping somebody to fill out a pulse form, why somebody might say no CPR, no intubation, why somebody might say comfort-focused care only, and that these are not like saying like, we are sort of, withdrawing care, or we are giving less care, because often when somebody is shifted to comfort-focused care only, the amount of care that they are getting can actually be more. And so, rather than withdrawing care, you actually could be giving more care, but it's care that is more focused on treating symptoms and keeping people comfortable. And again, I really sort of highlight how important this concept, this phrase is when you're talking to families or caregivers. Imagine if your loved one could look on themselves now. What do you think they might say that they would want? So one of the most difficult things to talk about in advanced care planning when it comes to dementia is the whole issue of tube feeding. Because generally speaking, everybody on a dementia course will eventually arrive at a place where it becomes really sort of difficult or even dangerous for them to swallow. And that can be really, really alarming for families. And it can be really, really difficult for care clinicians to talk to people about. We can sort of, in some ways, sort of intellectualize this and say, well, there's been many sort of randomized controlled trials that show that tube feeding does not make people more comfortable. It does not prolong life even. It causes more suffering in the form of aspiration pneumonia. And we can know that, and we can sort of like be clear in our heads that there's really shouldn't be a role for artificial nutrition in sort of late stage dementia. But that's easy. It's easy for us to intellectually know that. The tricky part is how to talk to patients or how to talk to families about that in a really kind of empathic sort of and compassionate way. And I think and the key is to sort of really sort of think through how to have that conversation in a caring, empathic way, and having sort of phrases ready sort of at your fingertips, like, I am worried that tube feeding wouldn't fix what is really this very slow dying process that your loved one is going through. And we really are, my experience and the healthcare community has been really able to carefully tell that it doesn't make people more comfortable, and that even though many people associate sort of food with love. Maybe people sort of are concerned that sort of being hungry could lead to a lot of discomfort. We have a lot of experience that really indicates that, you know, we can do sort of like careful, you know, sort of you know, adjusting people's diet or giving people food if they really seem to be sort of like asking for it or wanting it, but that otherwise we can really feel very sort of like clear that especially putting in a peg tube is in no way going to make somebody feel better. That in fact, it's going to make them feel worse, and that is not something that we would sort of ever sort of recommend. But there are many things that we can do if people are not able to eat to keep them comfortable. And, you know, I worry that the tube will cause this, that will cause aspiration pneumonia, will cause bed sores, that you can, so it will cause agitation and discomfort. And that's why you wouldn't recommend a feeding tube for them. So a much more complicated, controversial, legally murky question is the issue of assisted feeding. And so this is before somebody might need a sort of artificial nutrition, but the many people have sort of like started thinking about assisted feeding as something that some people say, gee, I don't think I would want assisted feeding if I wasn't able to feed myself. You know, so this is, you know, the kind of hand feeding question that that there is a lot of controversy about. And I think a lot of it, the controversy boils down to whether to think of assisted feeding as sort of basic care, sort of like bathing somebody, or is it really thought of as an intervention, like that you can sort of say in advance that you would or would not want? You know, is it a medical care intervention, or is it is it a basic care, like sort of keeping somebody sort of like bathed? And I think that there is not sort of consensus as a society for us. And yet many people do feel really, really strongly about it. Many people feel really strongly that if they had really severe dementia, so that they weren't able to feed themselves, that they would not want assisted feeding. And so there are at least two directives that address this question that I'm aware of. So one of them is actually End of Life Washington has one. Another one is End of Life Choices in New York, which have essentially the documentation where somebody can say in advance that if they had very late stage dementia, they would or they would not want assistance with sort of eating and drinking. And again, this is a very controversial topic that these documents have not been around long enough to go through the legal challenge that they will eventually sort of face, because until somebody has filled one of these documents out and then is later in that late stage dementia where it could be legally challenged, the courts have really not sort of weighed in on whether this is sort of basic care, which you can't sort of say that you wouldn't want in advance, or is it a medical intervention that that would fit with other medical interventions that you should be able to decline in advance? Controversial. You know, I definitely point towards people towards either the End of Life Washington document or the End of Life Choices New York document if they have strong feelings about this, because if people do have strong feelings about it, we want to know about it. We should know about it, and they should be encouraged to fill one of these documents out. All right, so just the kind of take-home messages for advanced care planning and dementia are, you know, before dementia, really important, I think, to at least offer everybody a dementia directive. When mild dementia is occurring, the most important thing to fill out, you know, and even before mild dementia, mild cognitive impairment, is fill out a durable power of attorney for healthcare so that we know who not just your spouse, but the alternates to your spouse would be while you are still have the capacity to express those wishes. When people are entering into more moderate or severe stages of dementia, the pulse form is absolutely appropriate and incredibly valuable to help somebody fill out. And the key phrase that I share as part of the cognition primary care training is, imagine if your loved one could look on themselves now, what might they say that they would want? All right, so that is an overview of advanced care planning for dementia. I'm excited that we have some time for discussion, because you are all like a very advanced audience. And so I'm sure many people have interesting questions or sort of perspectives to add. And, like I said, I have plenty of anecdotes that I can share from my own practice as well, on how this process can play out. So thanks so much.
Barak, thank you so much for not just your clear kind of passion around this and all the resources, just the wisdom of doing this work day in and day out. It's really what a benefit for our community and for our folks that we serve. And feel free just to unmute and start chatting. We don't have to call in, folks.
I had a question, if I could jump in. And Dr. Gaster, thank you so much. I've heard you talk about advanced care planning for people with dementia a few times, and I feel like I learn more each time. And every time I hear you, I just wish everyone could hear this conversation. So thank you so much for what you're doing.
You can do it too. You can do it too.
I'm learning from you. We had a fairly tricky client situation, probably 6 months ago. And it's actually something that's come up where, kind of within the context of thinking about goals of care, how that changes or not if something accidental happens. So for context, this is a client we had been working with for a very long time. So we knew him well. He certainly had all his documents in place, had done an advanced healthcare directive indicating that he would want comfort care when appropriate. He had a professional fiduciary serving as his attorney, in fact. And he was in his 80s, I would say kind of middle stage dementia, was also fairly impacted from a stroke that he had had many, many years ago, I think when he was in his 50s or 60s. Despite all of that going on, I would say he had a lot going on in life positively, fairly engaged, seemed to have a pretty good quality of life. And a very tragic situation happened at his adult family home, where he was being transferred with a Hoyer lift and the straps broke. And he had a fall to the ground, and the paramedics came out. They thought it was pretty apparent that he had at least broken his hip. So of course he got sent to the hospital. He was alert, oriented, knew it was happening. And then all of a sudden something changed, and it was obvious he was going to die without life-sustaining measures. So I don't know all the details, but they did some basic things in the hospital just to kind of keep him alive long enough to, one, try and figure out what was happening, and then for someone to make a decision. And it was very tricky for his power of attorney because it was accidental. Ultimately, they ended up letting him go, but it was a very hard decision because of that, because of those circumstances. So I guess I'm just curious, if something's accidental, does that change how you think about somebody's pulse and their goals of care?
Yeah. Oh, what a terrible story. I'm so sorry that that happened. And it's and it does bring up the point of how, as much as we can kind of try to kind of like imagine and foresee and sort of, think about like future scenarios, that there are, so many variations on sort of how things can play out and what that means. And so, so for that, in this scenario, my advice would be to not let the how did somebody get into the situation they're in really sort of shape what the decision is, as much as like, here's the reality of where things are right now. And whether he tripped and fell on his own volition, or tripped or fell because somebody sort of like dropped the ball, that the still the overall risks and benefits of something like a big operation are the same. Like regardless of how he fell, those same really tricky sort of risks and benefits are the same. And that if you could sort of like transport his past self into sort of the current situation, and he would probably say, oh my goodness, like, no. In the same way he would have said, don't do some big hip operation on me if I trip and fall myself. He would say, don't do that on me if somebody sort of accidentally sort of dropped me. And so it's like it's a heartbreaking and horrible situation of like, how did this happen, and who is to quote unquote blame. But that doesn't really change the sort of, it shouldn't change the decision making of like, what would this person want, and what are the pros and the cons of proceeding with this intervention or not proceeding with it.
Thank you very much. That's helpful.
Karen.
There we go. Yeah, so my name's Karen Hayes, and I serve as the caregiver representative for Echo Dementia, having cared for my husband, who's passed now, who had a presumptive Lewy body diagnosis for 8 years. And when he was first diagnosed with mild cognitive impairment in 2015, there wasn't any of this kind of specific advance directive, and we didn't really stumble onto something like that until 2020, when we redid all of our estate documents, and we chose an attorney who was an elder care specialist, a state law attorney, and she had a wonderful checklist, things to consider and so forth. And it was like, yeah, these are the questions that should be asked. But it was sort of the first time of myself and my husband sort of alerting to that. But I wanted to appreciate something Barak said about getting those documents filled out in the early MCI years, when people still have some capacity to know themselves. But also, I did not at all understand. And I took a very hands-off approach. My husband is a physician, and we were both very, had a lot of locus of control over our own lives. And I didn't really, what's the right word? I didn't really get involved in his dementia process in a hands-on way until probably close to 3 years into it, because I didn't really understand executive function, and he seemed to be just his same kind of quirky self, and just a little more forgetful, blah blah blah. So all that to say is, I wish we would have had somebody like Barak, or somebody like any of you on this Echo, kind of guiding us through those early years. And if somebody had given me permission, or given me a little nudge that I should be, as his wife, more involved in some of this advanced planning, and again, who knows what my own denial was, and him not wanting to deal with it. There's nothing we can do, don't tell anybody, keep it a secret. That was the phase we were in for the first couple of years. And it would have been great to understand this, that it can be an early thing with dementia, that you can no longer conceptualize your future. And so, yeah, so I just want to applaud all the work that's gone into a document like this, and really encourage all of you who are on this call, or anybody listening to the tape, to really start engaging. And I know it's a tough time because they're losing their independence, and you're implying that they're losing their independence, and it can be tricky. But again, it might take 6 months, it might take a year, but just kind of whittling away at it and not dropping it until it's too far gone, for them to really be able to retain some autonomy by expressing their wishes on paper.
Yeah, thank you so much for sharing that.
While people are thinking of other questions, Barak, I got pulled away from a little bit. Did you mention the legal planning toolkit from the Dementia Action Collaborative?
I did not, but please do.
Okay. So one of the resources from our state plan and the Dementia Action Collaborative, I'll go ahead and share my screen if that's okay, is this legal planning toolkit, which is available for free for people living with dementia and their families, or MCI, or anybody. And it has a lot of what Barak has discussed in terms of, kind of just some overall basics, power of attorney forms, the healthcare directive forms, including Barak's and one from End of Life Washington, and kind of a checklist. So this was designed for folks that don't have access to an attorney and to demystify some of the process. So that's available through the Dementia Action Collaborative website. We'll send that out also. And then for a little while, I don't know if we're still doing it, but I can double check. At the Memory Hub, we had someone from the Pro Bono Council, I think, doing kind of legal consultations, drop-in legal consultations around advanced care planning and other legal documents. So some other resources here in the Seattle area and in the state.
Well, this is such wonderful information. I keep racking my brain a little bit of just how to get information like this out, because I imagine this is all. I've invited people to this meeting, and it's like every time I come, I'm just like, wow, I'm so surprised that I'm learning new things every time. And I should already know all this by now, but some of the points that come out, the fine details that come out are so important that it's wonderful to have just ongoing conversations like this. And so I'm really grateful for this collaborative. Yeah.
We're grateful that you're part of it.
I think one thing I was thinking is that it feels like there's so much taking our attention in this modern world. There's a lot of YouTube and TikToks and all these things that are trying to grab our attention for sort of for more marketing reasons. It really would be amazing if there was more of a, I don't know, if there was more of a counter to that had information, like really important information like this to counter it. So I'm not quite sure. I'm just going to throw it out there that it's just, this is really, really good information. I think sharing it in appointments is the way I can kind of share it, but it's like there are so many resources there that they can also be kind of overwhelming when someone comes in with mild cognitive impairment to say, oh, I've got so much information for you. Here, let me show you all these websites. And then I'm still kind of putting together how I want to present all the information. And I think the advanced planning, I think my main takeaway today is just doing it before there's cognitive impairment is so important, because I just never occurred to me too that how difficult it is to make decisions once you have the cognitive impairment too. So that was my takeaway today for sure.
Yeah, and I think that's like a really good point about how this is an ongoing process, and that this is, it's not just sort of like one and done and then like that's it. This is a conversation that you have with somebody sort of throughout the life course. I mean, I generally don't necessarily recommend like a big sort of deep, serious conversation before people are age 65, because the value of that is smallish, and it's not wrong for people to do it, but it's not really what I think of as like a high priority for primary care. But once people do reached the age of 65, then this is a conversation that should be starting. But that once you have it, it is important to revisit it. But you want to also be cautious about not having it be, the first thing that you talk about after a diagnosis of mild cognitive impairment. That shock of like, oh my God, what do you mean that I might have Alzheimer's disease, is a really like emotionally difficult sort of like moment, and one of the worst things that can happen, that kind of diagnose and adios phenomenon is, well, get your affairs in order, I'll see you next year. Like, you don't want to be doing that, and you want to really like, I'm here with you, we're going to walk this path together. There are many, many things that we can do to maintain your brain health and to improve your quality of life. And so, at the bottom of that sort of list is going to be advanced care planning, but it's not going to be, you want to make sure you've sort of like engaged and sort of like been compassionate to set up the other things first. And so it's not going to be on that first visit. It might not even be on the second visit, but you definitely want to, until you like feel like you've completed all of the sort of planning for their mild cognitive impairment to see you next year, you're going to want to make sure that at some point in that sort of like seeing somebody back every month, that you have addressed the advanced care planning aspect of it. And and it's another reason why Medicare annual wellness visits are still really, really important and useful for people even after they have a dementia diagnosis. Like, it can be so tempting to say, oh, well, we're not going to do any more preventive care. We're not going to give you any more colonoscopies or mammograms. So like, and isn't that what annual wellness visits are sort of really all about? But like, really, no. And I think that's, the big, giant, laborious health questionnaire for Medicare annual wellness visits has all of the activities of daily living questions in it that are really important to sort of track as people sort of go through a dementia illness. But that it's also a really, really important and valuable thing that you can do at a Medicare annual wellness visit, which is to talk about advanced care planning. And that if you spend more than 15 minutes talking about advanced care planning at an annual wellness visit, you can add the advanced care planning code as a modifier to that visit and double the number of RVUs that you get for that annual wellness visit. And so just like a really, really solid, important sort of like part of advanced care planning is embedding it in Medicare annual wellness visits, especially as people have a dementia illness. And if you go to our cognitionprimarycare.org website, there is a one-pager handout that shows how to bill for advanced care planning at an annual wellness visit. And it's really, really easy. The documentation is really, really simple, and it really is a lot of our views.
We'll look forward to hearing more about that in September. Well, I'm realizing we are pretty close to time. There are a number of resources and other things that were kind of put into the chat. We'll be sure to compile all those and send those out, including the resources that Barak has mentioned today. Barak, thank you again so much for doing this. Just for 1 second here, and we'll wrap it up. Just a reminder for any UW faculty, staff, or students, that's the number. I just tried it, it worked, so that's good. And then we've got 2 more in our kind of top 10. I'll be doing the next one on May 10th, talking about non-pharmacological treatment of MCI and dementia. And then our own Dr. Mimi Pattison ending with palliative care and hospice for persons with dementia. We'll be pleased to reveal the rest of the didactic schedule for the rest of the year. Some great stuff coming up, and thank you all for your suggestions and input. So that's that. You will receive, as always, our 1-minute post-session survey, and thank you for all of you who filled that out. It's part of how we've gotten to where we are today. Look forward to reviewing your feedback. So with that, I think that's it. Yep. I will wish you all well, and have a lovely weekend, and we'll see you next time.